Good morning, everybody. Assalamu alaikum. Thank you for the kind introduction and for the kind invitation. It is always a pleasure and an honor to be with you. And congratulations for this fantastic event. I remember a few years ago when we signed this memorandum of understanding with SSBMT, and it is now flourishing thanks to the efforts of all of you, and especially, of course, the leadership of Dr. Al-Askar. I do apologize I wasn't able to be with you today because of some local commitments related to my PhD students defending a thesis later today. So I hope we'll be soon together. And thank you all for your contributions to the EBMT annual meeting 2 weeks ago in Paris. But also
to all your contributions to EBMT and to the hematology field. So for this morning, I was asked to provide an update about multiple myeloma. And I think you will hear during this event a lot about myeloma because it's a rapidly moving target. There are many advances. But I thought that for us as a transplant community and cellular therapy community, one important aspect that is hotly debated, and it was really a key topic of the last EBMT annual meeting, is the replacement or the contribution of cellular therapies, especially CAR T cells, to the field, especially in replacement to stem cell transplant, whether auto or allo. For instance, we know today very well, and this is highly reflected in the EBMT registry activity, that auto transplant for non-Hodgkin lymphoma is becoming less and less frequent, thanks to some major randomized phase 3 trials which could show the advantage of CAR T cells. And obviously, a key question for all of us today is whether CAR T cells will replace autologous stem cell transplant in multiple myeloma. We all know that autologous stem cell transplant for multiple myeloma is actually the most frequent, most popular, and the safest stem cell transplant approach. It is widely used across the globe, and obviously, if at some point we can demonstrate that CAR T cells are better or should replace, that will be a huge, I think, revolution in this field. Obviously, I don't think I have the right or wrong answer, but I will try to walk you through this problem and how can we tackle these issues. My disclosures, just for the sake of introduction, is to highlight, especially for the youngest colleagues and friends in the room, about the incredible advances we have witnessed in the field of multiple myeloma for the last 50 years or so. For 30 to 35 years, actually, we lived with the era of conventional chemotherapy. Then in the late 80s and actually early 90s, we had the development of high-dose melphalan and auto transplant. And this has become quickly a standard of care, and I will go back to this. However, we should acknowledge that later in the early 2000s, we have seen the advent of new families of drugs, especially the IMiDs, with thalidomide, later lenalidomide, more recently pomalidomide. We had also the proteasome inhibitors, first in class bortezomib, then later ixazomib and carfilzomib. In the mid-2000s, 15, something around this, we had the first monoclonal antibody. And I think this was really turning point in the field of multiple myeloma. We had also some small molecules like panobinostat, selinexor. But in the last 3 to 4 years, we've seen a new wave, actually, of treatments, namely immune therapies. And this is about cellular therapies, but also T-cell engagers, bispecific antibodies, and to a lesser extent, the antibody-drug conjugates. And there are now approved products for each of these options. However, if you look before the immune therapy era, actually the advent of all the new drugs, including the monoclonal antibodies, wasn't opposed to transplant, at least from my perspective. And actually, I'll show you data, it allowed to synergize and to improve the results of transplant. But now, I think maybe we are switching where the cellular and immune therapies are going to be opposed to transplant, and we'll figure out how this will work. My personal feeling is that probably CAR T cells will replace autotransplant or will take a major place. But I don't know when, actually. It may take some time. And actually, even if you have randomized trials, and they are ongoing, showing this, in many places across the globe, it may take a lot of time because of accessibility and affordability. First of all, just a quick reminder about the value of autotransplant. We are in a transplant meeting, in a transplant environment. It's a post-EBMT event hosted by SSBMT. And I would like to remind all of us that autotransplant is really well established since now the early 90s. First, thanks to the IFM trial, which could show the superiority over conventional chemotherapy. And this was later confirmed by other trials, including trials from the UK. There have been a lot of attempts to improve the conventional high-dose melphalan autotransplant. And the transplant community worked a lot, including EBMT and cooperative group studies, on whether we can do better than melphalan 200. And TBI was tested, bortezomib was tested, busulfan plus melphalan was tested. But at the end of the day, it proved that in terms of the balance of efficacy and safety, melphalan 200 is a standard of care. The first lessons from these studies were that actually the value of high-dose melphalan is by deepening the response. And when you deepen the response, you can improve progression-free survival. And in some studies, there was even an improved overall survival. Of course, I will not go through the details of transplant eligibility criteria, but I think as transplanters, you're quite familiar, although we may debate a lot the threshold, the age, whether it's 60, 65, 70, 75. It depends, I think, on comorbidities and frailty parameters. But definitely deepening the response and later achieving MRD negativity maybe has been a major step. And this was a background to further improve the procedure. And actually, one way of improving the procedure was about actually improving the tumor debulking process. This is what we call induction before the high-dose chemotherapy. And I will not go through all the developments. We started with VAD, we went to VD, bortezomib dex, TD, thalidomide dex, Lendex, VTD, VCD, VRD, but actually KRD, but actually today, I think it is well established that quadruplet regimens are becoming the standard of care and are allowing to improve the results of auto transplant. And for instance, this Griffin trial, similar to the IFM Cassiope trial, could show that dara-VRD, daratumumab, bortezomib, lenalidomide, dexamethasone is superior to the standard of care RVD because of a higher response rate, and most importantly, at the last follow-up, the very high percentage of MRD negativity. At end of consolidation, 47% were MRD negative with dara-VRD at the level of 10-5. And this has been also shown in a German multi-center randomized trial, actually using another anti-CD38 monoclonal antibody, namely isatuximab, and exactly showing this 50%. So clearly, we have moved radically 180 degrees from less than 5% CR to 50% MRD negativity. So you can appreciate that the auto-transplant field has really improved, and that is making the bar quite high for CAR T cells. Please bear with me. So now, if you look at the relatively long-term follow-up of the Griffin trial, actually we're talking about 87% PFS at 4 years. And this is going to be like 85% at 5 years and so on. So we're talking probably in the standard risk cytogenetic patient, because obviously myeloma is a very heterogeneous disease, but for the sake of time, I'll not go through all of these details. But definitely, we're talking about more than 10 years of median overall survival, which makes it difficult, actually, to prove things in the frontline setting. And actually, just to echo the story of the high-risk cytogenetics, probably there will remain a room, in my opinion, in the future for the chemotherapy, the high-dose melphalan, in those patients with high-risk cytogenetics or even high-risk genomics, because now probably we're going to move from the cytogenetics maybe to whole genome sequencing in multiple myeloma. And you can appreciate that the standard risk cytogenetic, this is likely where we will achieve long-term outcome and cure. And actually, just to highlight the importance of auto-transplant. So here I am advocating and pushing for auto-transplant, not to forget about it. In the high-risk cytogenetics, we probably even need a double auto-transplant. Of course, while the topic is about comparing auto to CAR, you may wish to ask me later about why not combining auto-transplant plus CAR T cells, because at the end of the day, maybe this would be a good option. Nevertheless, in the high-risk cytogenetics, double is shown, is still recommended. We have this latest IFM data showing the feasibility of double auto in this population, but also, and this is again another important finding, if you want to bring these high-risk patients closer to the standard risk, I'm not saying equivalent, closer to the standard risk, maybe that is the path forward, because you can achieve 60% MRD negativity in these patients. The follow-up is relatively short, but these curves are a good starting point in my opinion. So you can see the background. The auto data are quite solid, even double auto. The safety is very good. I didn't mention it, but the mortality is less than 1%, less than 1%. And in many centers, it's almost 0%. It has been a long time since we didn't see a transplant-related death with auto transplant for myeloma. It's a different story in lymphoma. So it is important to see that we are the starting point. The bar is very high in terms of safety, but also in terms of efficacy. And you need to beat this with your CAR T cells. Of course, probably there are patients attending and listening to us. I'm not minimizing the side effects of auto transplant in the short term, on the short term, when it comes to mucositis, when it comes to diarrhea, when it comes to neutropenia, febrile neutropenia, the need of hospitalization in many places, the need to travel to a dedicated transplant center, etc. But at the end of the day, if you are able to go to a transplant center, then the safety and the efficacy is very high. Well, the transition is, we as transplanters are strong believers in the power of immune therapy. In auto transplant, we're more relying on the power of chemotherapy, which is still very, very helpful. I mean, you know all this. But in the allogeneic stem cell transplant field, we know very well about the immune-mediated anti-tumor effect. And this is now fascinating with the tools we have, let's say, in the autologous setting, thanks to CAR T cells, where you can educate, you can engineer the patient's own T cells, transform them, and I'm sure this community is quite familiar with the CAR T cell process. And I would like to congratulate and praise the effort of SSBMT and Dr. Alaskar to bring actually CAR T cells, academic CAR T cells, into the region, because this is very important. But also immunotherapy, because it's not only about cellular therapy. I think we need to think broad now. It's not about transplant. It's not about CAR T cells or cellular therapy. It's about curing a given disease. And for this, you need to rely on all options. So we should not ignore also the bispecific antibodies, the T-cell engagers, which are relatively easy to use, accessible, and are providing a sort of an in vivo immune therapy. So for CAR T cells, and I think there will be a talk by Dr. Rodriguez Otero, who was featured at the Presidential Symposium during EBMT. But we know that we have, for instance, this ide-cel product, which was approved thanks to the KARMA trial. I have presented this several times. You know the data. In highly relapsed refractory patient, median prior lines of 6, you can achieve 9 months of PFS. You can view it as the glass is half full or half empty, but these are quite good results when it comes to patients who are supposed to be in palliative care. There is another product, another construct approved in multiple myeloma, CAR T cells, namely cilta-cel. And the results of cilta-cel are quite incredible, actually, because you have 98% of overall response rate. And if you look to the PFS and overall survival, especially in those patients who are able to achieve deep MRD negativity, the results are very impressive. And you may have seen yesterday, so we're Friday, yesterday, Thursday, that the company of cilta-cel has applied actually for approval in earlier lines of therapy, in earlier relapse, thanks to the results of the CARTITUDE-4 trial, which will be presented at EHA in the presidential symposium in 2 weeks. So, and this is in line with the fact that we have already data showing that we are able, and we do have the capacity and also some data that we can use CAR T cells early in the course of the disease. And actually your T cells are likely better. And you would imagine where I'm going there. I'm trying to push the CAR T cells from the end stage progressively into the first line, just showing you, walking you through how we can move forward. And actually, in the KarMMa-3 trial that will be presented by Dr. Rodriguez, actually, you can use them earlier, and they are better than standard of care. And you have also, in the KarMMa-1 pivotal trial, showing efficacy in early relapse after frontline therapy. It is also true in one of the cohorts, cohort B of CARTITUDE-2, showing actually that they can be used in early relapse, so early, less advanced disease. So if things are working end stage, intermediate, earlier, then why not pushing them into earlier relapse and later first line? And this is exactly, as I mentioned, what Dr. Rodriguez will present to you. And this is exactly what Dr. Ainsley will present in a couple of weeks at EHA when it comes to the CARTITUDE-4 trial. So CAR T cells, they are effective. I didn't mention the safety, but it is now well known when it comes to the key issues, CRS and neurotoxicity, the cytokine release syndrome and neurotoxicity. Interestingly, in multiple myeloma, the incidence and severity of these side effects is, in general, much lower than what you see in lymphoma and even in acute lymphoblastic leukemia. So it doesn't look like that in myeloma, at least with these CAR T cell constructs, which are targeting BCMA, but I'm sure you are aware of this because I didn't mention it. We don't have these safety issues, and they work well. So how to move it forward? Given the very high bar of efficacy I showed you, 90% PFS at 4 years now, with a quadruple Dara VRD or isatuximab VRD, 50% MRD negativity, excellent safety, less than 1% mortality. So if you want to move it forward, you really need to have a very robust, well-designed, well-powered phase 3 of randomized trial. And this is exactly the European Myeloma Network 28 CARTITUDE-6 randomized trial, which has, I think, started or about to start, at least for us in France. We will start, I think, in a couple of weeks, including patient there, where they are randomizing standard of care, Dara VRD, so very fair comparison, auto transplant, Dara VRD consolidation, lenalidomide maintenance, 2, Dara VRD induction, 6 cycle, cilta-cel, lenalidomide maintenance. So I think the design is fair, very well balanced. There's no bias. There is this issue of maybe doing apheresis immediately before the induction. We'll see the feasibility. The question here, and you may have noticed that one of the advantages of using CAR T cells, at least today, the way we do it with cilta-cel and ide-cel with the label and the indication, is that we don't use maintenance therapy. And here, and this is huge for the patient in terms of quality of life. They love it, the treatment-free interval. So here, it looks like we are reintroducing the concept of maintenance, which we have with auto transplant. So we are maybe switching and changing the philosophy of CAR T cells without maintenance. But I think we have already some phase 1 data. For instance, here, these data from colleagues in China, in Shanghai, small biotech, developing dual targeting CAR T cells. And this was presented at the last ASH meeting. Small number of patients, but definitely you can do them frontline after VRD induction, and the results seems to be very promising. But obviously, it's only 16 patients, and you can appreciate no comment, 100% everywhere when it comes to response and MRD negativity. So when we look to the first line treatment, actually, you can see that if it comes to response to MRD negativity, even in resistant disease, CAR T cells are ticking the boxes. They are doing well. Single administration, that's true. Short-term side effects, in general, I had a lot of patients telling me who had auto transplant and then CAR T cells at relapse, oh, why you didn't do CAR T cells before? Because the side effects were much milder. We should not ignore the pharmacoeconomic evaluation, because it's not only about the rich countries and those people who can afford it. It's about accessibility, availability, and we do have a shortage of CAR T cell slots these days, and affordability. So we need to pay attention to this, that we have to allow access to the broader number of patients. We should not ignore the need for bridging therapy, and it may not be very easy. Well, maybe in the frontline setting, well, you do your induction. But in the relapse setting, we don't know yet, although I would say it would be a good problem to have, what are the long-term side effects? Well, because if I'm talking about long-term side effect at 10 or 15 years, well, it means we are anticipating the patient are going to be alive, which usually the patient like. We should not forget that for the time being, these CAR T cells are being used only in big academic centers. And the question is, if you're using, for instance, frontline an anti-BCMA CAR T cell, in the time of relapse, actually, probably you will need different constructs if you want to rely on CAR T cell. But maybe the problem would be solved with the bispecific antibody. So as you can appreciate, there are more questions than answers, but it's always better to discuss a problem, even if you don't find solutions, and avoid, hiding it. I think we all believe that CAR T cells against BCMA today, but also GPRC5D or other tumor antigens, are effective, safe. They are feasible even now in early relapse progression, thanks to KarMMa-3 and CARTITUDE-4. There are new modalities, including the fast CAR, because the manufacturing duration is important. And now, I think the trial in newly diagnosed patients comparing or challenging auto have started. But also, I didn't mention this, but there are trials outside the auto setting. So with this, I'd like to thank you all for your attention.